that needed, and that is only talking about the access. It does not talk yet about the quality of the treatment services provided there. So we hope that in this morning session and from all our speakers, we can explore this topic a little bit more. And it's my huge pleasure in reality to give the floor to my colleague and friend, I have to say, Dr. Elisabeth Saenz, who has been working with UNODC for over a decade now and has been very instrumental in the development and implementation of all our global programs on drug dependence treatment and care. And so, Eli, floor is yours.
Thank you, Anja, for the generous presentation. Indeed, we are, I think, more friends than colleagues these days. But it is my honor to be here today presenting to you the International Standards for Treatment of Drug Use Disorders. As Anja mentioned, I'm coordinator of global drug treatment projects, and the development of the standards was embedded in this global initiative that we have with our colleagues in WHO. So this is the outline of my presentation. I'm going to talk about systems and services, why and how we develop the standards, what are the settings where drug treatment interventions ideally should be provided according to the international standards for treatment of drug use disorders, and the importance of a recovery support-oriented approach to drug treatment services. So think for a moment, why do we need standards of care in drug treatment services? Do you know of existing standards, both at international level or in a region or in your countries? Who is responsible in your region, in your country, to ensure that the treatment services that are provided for people affected by drug use disorder are of a certain standard, of a certain quality? So this is what we need to keep in mind, because unfortunately, the reality in many countries is that, like Anja just said, many people, indeed, according to the latest World Drug Report, only 1 in 7 of the people that are affected by drug use disorders get access to treatment services. So, and this is despite the fact that already back in 2004, WHO recognized the character of substance use disorders as a health issue, not as a moral or a criminal act. So when we ask member states in the annual report that they send us every year to produce a World Drug Report, what kind of services you have, what kind of policies you have, what is the access of your population to these services, we get more or less this kind of numbers. 90% of the member states acknowledge that they have a drug strategy, drug demand reduction component. 80% report that they have drug treatment services, and there is high level of participation of NGOs, and 37% report that still the drug treatment services remain unfunded. But when we look at what are the real causes of why access to treatment services is limited around the world, we see that stigma and discrimination continues to be at the top of that list, because even health service providers are very stigmatized or stigmatize the people with drug use disorders, because the services are usually not available, or they are centralized in the big cities. Because, and this is all the reason of ISSUP, to increase the capacity, because we know that in most countries, the capacity of the professionals to provide these treatment services is limited. There is no connection in many countries between the drug treatment system, which in many countries is still under the arms of the Ministries of Justice or Ministries of Interior or anti-narcotic agencies, with the overall health system. Or because the system, the services are not adapted to respond to the needs of special groups, because there is registration in many countries which makes patients reluctant to come and ask for help and attend to the treatment services, and then all other reasons why. The other circumstance, the other situation that we see in many countries is that the treatment services that are provided, when they are called drug treatment services, are of low quality. And this is on the basis of what? We know that treatment services, the main goal of treatment is to reduce the symptoms, to increase the functionality of the patient, either physically, emotionally, and psychologically, and of course, decrease the risk of health and social negative consequences of drug use. So what and why international standards for treatment of drug use disorders? For those of you that were here yesterday, you might have heard that in 2016, the United Nations had a special, the General Assembly had a special session on drugs, and the outcome document or the resolution out of that meeting recognized drug dependence as a complex multifactorial health disorder. And this was acknowledged and signed and endorsed by 193, the 100% of the member states of the United Nations. Furthermore, the outcome document calls UNODC and WHO to develop, and there are previous resolutions in this line as well, asking these two organizations to develop these standards, to use these standards to provide guidance to the member states in terms of training, increasing the capacity of professionals, and also to support member states in creating mechanisms to accredit, to regulate, to somehow support member states in the monitoring of the quality of drug treatment services that are provided. So the international standards of treatment of drug use disorders were then developed by both organizations, UNODC and the World Health Organization, in order to provide a framework of reference to ensure that treatment services are ethical, are humane, are based on scientific evidence, and of course that comply with human rights strategies. So it's a sort of, after doing a large literature review, is a sort of a compendium of what we know exists, what there is evidence for in terms of effectiveness for treatment, and then helping member states use these standards as a reference for the development of their own systems. So the principles of treatment according to the standards are taken from the original document of UNODC WHO principles for drug dependence treatment, which say that treatment should be available, accessible, attractive to patients, appropriate to the needs of the patients, based on scientific evidence, respond to the individual needs, and should be ethical and according to standards. They should be provided primarily in the health and social system, and we will see why. They should ensure clinical governance. Also, importance of coordination between the health and the criminal justice system, and integrated treatment policies, procedures, and strategies should be promoted. So other important principles that are embedded in the standard is that treatment policies and the resource allocation should be based on effectiveness, cost effectiveness, and of course universal health coverage, the need for qualified staff, the need for informed consent from the patient, the need to keep patients' data confidential, and the need for compliance mechanisms to be in place at the level of treatment services. So we looked into previous documents developed by either both organizations jointly or separately by the organizations, such as the principles, the document from coercion to coercion, the international guidelines developed by WHO for pharmacological treatment, for management of overdose, and the MHGAP. And based on all these documents, we came with the development of the standards. Another thing that was important was to think, okay, what really works? What are the therapeutic interventions that are really effective, that have scientific evidence that they work? And basically they are in this list, with always the premise that we know that not all treatment, not all formulas work for all patients. We need to personalize the treatment services. Another important concept embedded in the standards is the concept that drug treatment services should be provided within this principle of public health that says that the most cost-effective interventions at the lower cost should be provided. Yeah? So when we look at this pyramid, we see that at the base of the pyramid, we have the large population, while at the top, we leave it for the services that are more complex and that indeed, because of the complexity, represent more cost and more needs for the treatment services. But I will go into this in more detail later. The other key concept embedded in the standards is the thought that in a chronic relapsing disorder, And when we acknowledge that there are different stages in the progression of the disease or the disorder, what are the conditions in which patients will come to the treatment services? So the standards are based on the fact that people will come to the services or request services, or we will get them out in the streets, for example, in outreach services, because they are either intoxicated, because they have already reached a level of harmful use, or because they are already dependent or addicted. So the interventions and the services should be structured on the basis of these three stages in which the patient most likely will come demanding the services. So this is the structure of the standards based on all these, let's say, principles that I mentioned before. The document, which is now being finalized after conducting a field testing process, has an introduction, the principles, and then it goes through the different settings that the experts that work in this document agreed were the necessary, let's say, places or spaces where the therapeutic interventions ideally should be provided to the patients. Then the standards also have a section on special populations or needs, special needs of certain population groups, and then it goes into describing what are the characteristics of an effective system. So for each chapter, the document looks into the setting, yeah, I will go into that later, what are the target population or clients are suitable, that the interventions in that setting are suitable for, the objectives and goals of treatment in each of these settings. This is very important because usually providers tend to either overestimate or underestimate the expected outcome of the interventions that are provided at each setting, so we cannot have full abstinence as the main goal of outreach services, for example. Then what are the different treatment modalities, the rating of the evidence for each of these settings, recommendations, the staffing needs, and then the criteria for intervention completeness. So when do we consider that a patient has completed a treatment at the particular setting? So what are the settings included in the standards? So when you think back in your country and you think about treatment system or treatment services that you are familiar with, what settings can you think of? What are those places, spaces, either in the health system or at large, that exist where the therapeutic interventions are being provided? So when we think about our population and when we are, the standards are a framework of reference. When we are planning for our services or for our system and our services, we need to remember this pyramid, yeah? We have the general population at the bottom, no drug use, and then people will start moving at the base of the pyramid with initiation of drug use. Eventually, some of them will move further up with frequent use, and a proportion of those that continue to use, and those that were here at the prevention session learned a lot about risk, vulnerabilities, etc. And then we come to the tip of this pyramid where we find that around 10%, 1 in 10 of the people that at the bottom of the pyramid started using drugs will eventually develop a serious dependence or addiction problem. So when we think about the interventions in the system, we need to keep this into account because at the bottom, we have, of course, prevention, indicative prevention, or already brief intervention sort of therapeutic processes, and maybe people will stop using drugs and go back and never need any services. While as people move towards frequent use, this might be the perfect time to intervene. And we need to think, well, but what kind of interventions do we need when a patient has a problem that is relatively early in the progression towards addiction, and what kind of interventions are more cost-effective at this stage. And then when we move at the top of the pyramid, then we see that these are the patients that are more difficult to treat, that require probably long life duration of treatment services because of the relapsing and chronic nature of the disorder that we're treating. And then based on this pyramid, I want to bring us to this other pyramid. Yeah, remember the initial one, that was the general population. and the general services, in the overall health system, when we are talking about drug treatment services or our system of services, then we are talking about the tip of the pyramid. The people that already have problematic drug use or that are already dependent with severe dependency or addiction, for which all these services are required. So according to the standards, we have community-based outreach, very important as the first point of contact with the patient, teams going out in the streets to find out the people that are in need of social support, of course, reducing the health and social negative consequences of drug use, overdose prevention, education, any intervention that can also invite the patient, attract the patient to come and use the services. Screening, brief interventions, and referral to treatment. We know how important this intervention is, and it can be applied at large in the health system, but also in the specialized treatment services. And the idea is to identify who are the people that are at risk already of developing a problematic drug use. Patients can receive a brief intervention, and when we identify more severe cases, they can then be referred to treatment. Then short-term inpatient. Short-term inpatient is for those patients that require a stabilization, either because of a psychiatric problem or because of an infection. Usually the patient can stay in short inpatient treatment for 1 to 4 weeks, usually is no more than that, and then can be referred to outpatient services with the frequency that we consider appropriate depending on the condition of the patient. So of course it's more resource intensive than outpatient, but not as resource intensive as long-term residential. And as you can see in this slide, in short-term inpatient treatment services, you can already start a lot of interventions, especially psychosocial interventions, aimed at engaging the patient in the longer-term treatment process. So remember, and this is a message for that detoxification alone is not treatment. We need to ensure that this is specific for the short-term inpatient. We need to ensure that the patient living the short-term continues with the treatment process after that. So outpatient treatment services setting is considered the most cost-effective because it's low intensity and a lot of therapeutic interventions can be provided from psychosocial treatment to pharmacological interventions. There is the best scientific evidence in support to this modality of treatment services, and of course they can be applied in different settings. It is of course also the ideal setting for everything related to prevention of blood-borne infections, HIV, hepatitis C, etc. I said this already, outpatient treatment services are the ideal setting to continue with pharmacological treatment for patients that eventually need this service, either with agonists or antagonists, depending on the existing modalities in each country. And of course, also for the treatment of co-occurring disorders. These are the psychosocial treatment interventions recommended at outpatient. And then we have the long-term residential treatment. And I want you to think in your country, in your system of treatment, how much of long-term residential services you have. Because according to the international standards of treatment of drug use disorders, this modality should be reserved for those patients that have tried several modalities of treatment and have failed, patients that are in a severe state of the condition where the goal of the treatment is to break with this cycle, this living style of the patient, and the therapeutic community in this case, which is one of the modalities of long-term, become the therapeutic intervention. So to finish then, the importance, international standards highlight the importance of developing drug treatment systems that are oriented and guided by the ultimate goal of recovering the patient, of social reintegration, of using and taking, bringing back the person to fully use the capital, the human capital of each human being. So treatment services need to, of course, consider employment, family, housing, mental health, and all the long-term needs of a person affected by a chronic disorder. So this is what the pyramid showing how the outpatient at the bases, short-term inpatient, long-term, and the connections of the recovery-oriented, let's say, framework or guiding principle at the top, then how screening and brief interventions should be provided along all the system, and then outreach services in the vertical axis as the intervention that allows us to go out in the streets and bring the patient to the different settings according to the needs. Just to mention the NIDA core components of a comprehensive treatment services. So when we look at these settings, remember that we're not only talking about health-specific interventions. We need to think not only at the core, but also all the surrounding areas that are affected in the life of a person affected by drug use disorders, and therefore the need for a multi-sectorial approach, for a multidisciplinary teams that should integrate the provision, the teams of provision for treatment services. So the international standards, again, are a framework. There is a lot of work, there is still a lot of ongoing work, and you will hear from the presenters that come after me in terms of adapting this document, of making it really feasible to implement in the different countries where we're working, etc. So in summary, the international standards are that. They are a framework that we're developing following the mandate of UNGAS. They describe the different settings that should exist in a comprehensive drug treatment system and the therapeutic interventions that have proven to be effective and cost-effective, they can be used for the development of policies, of strategies, the planning of services, monitoring and evaluation, and as we will see later, for the assurance of quality in drug treatment services. So thank you very much for your attention.
Thank you very much, Elisabeth. I think by now everybody in the room has a very good idea, so to say, what is in the international standards for treatment. We will nevertheless encourage you to take the document and read it. And as you already said, we'd like to kind of move and hear, in this case from Annette Dale-Perera, about the role of quality assurance in implementing evidence-based, ethical, and cost-effective treatment for drug use disorders. Annette has more than 35 years of experience working on substance use treatment and also standard setting, and she has been for the last 2 or 3 years already now working as a consultant with us on this journey to explore how we can implement further the international treatment standards. Annette, floor is yours.
Thank you so much, Anja. 35 years is a long time, and I suspect there's people in the room that have been in the field longer than I have. I started off on the front line, actually, as a psychologist, that's my background, but then went on to manage services, be a research fellow, and then ended up in government positions leading quality in my country, in England, for 15 years, and as a government advisor. And then after all of that, I decided to come back out and run National Health Services, substance use disorder services, to find out whether or not we'd actually implemented all the guidelines and standards that we'd been writing for the previous 15, 20 years. And I realized implementation is a real challenge. It's really, really difficult. So you'll get some of my wisdom on that. In my country, I'm known as the grandmother of quality. I know I don't look old enough, but I really, really, really am. Okay, on with the talk. So what is quality? Quality is something of a known standard or a degree of excellence. And what's quality in health interventions? There's a good World Health Organization definition that talks about it's the degree to which health services provided to individuals and patient populations, so population level as well, improve desired health outcomes. And to achieve that, the services must be safe, effective, timely, efficient, equitable, and people-centered. And these kind of themes occur time and time again in the world of quality assurance. So, what else is quality assurance? It's also a process. And I learned very directly that quality is a process when I was managing services in the UK. So I managed drug and alcohol services in a quarter of London in 15 prisons. And trying to keep the quality of those services stable over time was a challenge. So you'd get to the point where you could measure the quality of a service and it was going well and it was great, and then the manager left and the quality would go down. Or the staff team would change and the quality would go down. Or then we'd get a different challenge coming at us through the patient group. But I used to say, the challenge isn't the patient, it's our ability to meet the needs of those patients, because that's our job. So quality is a process. It doesn't stop. It's something you continually have to keep doing. And there is something in this about trying to embed a culture of continuing reflection on your practice and improvement. And it's also about being able to assure services and systems are effective, timely, safe, efficient, well-managed, equitable, and patient-centered. So we're trying to do all of these things, and it's not easy. Why is it important in substance use disorder treatment? Well, for a number of reasons. The first, I think, really is that our patients are entitled to the same quality of healthcare as any other patient group, and they're often marginalized and stigmatized and get poor quality treatment as a result of that. The other thing I'd like to say is that treatment is not neutral. So good quality treatment is effective, but treatment that's not good quality can actually have the opposite impact, and we need to be mindful of that. So we can make people worse if the quality of the treatment that we provide isn't good enough, or the system doesn't have the coordination so that when people gain outcomes in treatment and then they leave and there's not enough aftercare or community support, they relapse. And they're at more risk of dying. So we have to bear all of this in mind. Quality assurance mechanisms help us benchmark the services and systems against standards. They also help us recognize good practice, which I think is very important in our field because we don't recognize good practice enough. And it also helps us challenge poor practice. And again, that's really important. And get that continuous improvement. So the cycle that we have here, this cycle of continuous improvement, this is what we're trying to achieve. This is what we're trying to achieve in every service, in every system, in every country, in every region. Okay. So what's the relationship between guidance and standards and quality assurance? Well, I think that quality assurance mechanisms can be a really good way of helping us do that difficult task of implementing guidelines. So we have lots of guidelines nationally and internationally, and here's just a few. The International Standards for the Treatment of Drug Use Disorders, I'll call it ISTD-UD just because it's easier. We've got WHO guidelines. I know it's hard, I know. The language in quality gets very difficult at times. But we've also got things like, we've got the staff standards, we've got the professional qualifications, we've got, do people get supervised properly, etc. And all of that can come together in a quality assurance system that can articulate standards and criteria into statements that we can then identify the standards, collect data and evidence against the standards, compare practice to the standards, where we're not meeting the standard, improve, plan to improve, implement changes using evidence-based methodologies, and then re-monitor and audit and then keep going round that circle. We need to get that quality improvement cycle in every service. Okay. Now, in terms of the UNODC Quality Assurance Mechanisms initiatives, let me run through them. I'll give you the headlines now. We have a fantastic poster downstairs that I'll urge you all to go and see. It's done collectively by our wonderful colleagues in UNODC and WHO, and it's about the journey that we've been on in terms of the quality assurance mechanism. So this all stems from UNGAS 2016 resolution, where UNODC WHO were tasked to provide guidance, assistance and training to health professionals on the use of ISTD-UD and consider developing standards and accreditation for services at domestic level to ensure that We got qualified scientific evidence-based responses. Okay, so after this document was produced, the ISSUP, UNODC then convened a group of quality experts, or quality nerds. There's some of us in the room. Randy, you were on the group. You're a quality nerd like me. So this expert group was convened from people all around the world. And we looked at different quality assurance systems. We then came up with a couple of toolkits, one for services and one for systems, that closely referenced ISTDUD. We then piloted the Quality Assurance Services Toolkit in Afghanistan. We've now trained and worked with a further 11 countries to look at how this Quality Assurance Toolkit plays out. And now we've got new collaborative initiatives with other people that are doing work on quality standards. So the European Union EMCDDA have had a long history in working in quality assurance and quality standards. The COPOLAD group have got a long history, and Teresa's going to talk about that in a while. And we've come together to look at how we can, what's the overlap, and is there a set of essential standards? And then there's a new pilot of this that's been done in Nigeria. So I'm going to run through these very quickly and give you the key points from each of these projects. Okay, but please have a look at the poster. The development of the UNODC quality assurance tools was done we met first in December 2016. We reviewed a whole range of national and international quality assurance systems. And there's a lot out there, whether that's standards, whether that's accreditation systems, audit systems, registration and inspection, performance and outcome monitoring, etc. This is not a blank playing field. There's an awful lot out there. Some of it is generic to the country's health systems, and some of it is specific to substance use disorder. So, a range of QA systems actually already exist in many countries that might cover part of the substance use disorder treatment or treatment systems. So, whatever we develop has to be flexible enough to be able to fit with the country's existing mechanisms so that it can be culturally adapted to whatever's there. So, that's a real kind of learning point from us. ISTDUD is a very interesting document. It's seminal in the agreement that it got between all of the member nations. But it's a kind of a composite document that has advice, clinical guidelines, standards, advice on systems. So it's a real kind of composite document. And when the Quality Assurance Group looked at this, we figured that actually there was 2 separate quality assurance tools that should probably be developed from that. One for systems, be that at a country or a regional level, and one for individual service providers, because these are very different stakeholders. So they're inextricably linked, but they're different with different stakeholders. And the other thing to say is with the services QA, there's a lot of different types of services out there. We run outpatient, inpatient, residential rehab, outreach services, a whole gamut of services. So whatever mechanism we designed needed to be able to take account of all of those different services. So the headlines on the quality assurance system standards were there's just 5 standards. And the 5 standards are, in every area or country, there should be a local strategic partnership group. This is called different things in different countries, but something that plans and coordinates the local drug treatment system in line with the international standards for the treatment of drug use disorders that Elizabeth has just designed, in line with the pyramid, in line with the principles in the document. That this system needs to be based upon a routine and assessment of local need, because the population needs are very different in different countries. That there then needs to be a 3 to 5 year plan to bring the system in line with the international standards for the treatment of drug use disorders. That then services are funded in line with that, and there needs to be some kind of ongoing quality assurance mechanism to underpin the system and embed it. The services standards are different. So we've got a series of core standards and optional standards depending on the type of service that you provide. And the core ones cover core management, core care, and patient's rights and responsibility. The centrality of the patient and patient feedback to the UNODC quality assurance tool is paramount. And I'm sure Randy will talk with us about the very important nature of patient feedback in all of the work that we do. There's also some optional standards that you pick depending on what you provide. So it's kind of a pick and mix system. And those are different types of interventions, settings, and target groups. So the key points from this is that many countries, they already have some quality assurance mechanisms. And they cover things like the management of medicines. They might cover staff qualifications. They might cover hospital registrations and the way that hospitals have to operate. They may cover rules around consent and confidentiality in the legal framework in the country. Okay, and people say, why have we got the emphasis on management here? Well, there's a fairly good evidence base from the stable of people like Dwayne Simpson et al. That services that are better managed with better qualified and competent and compassionate staff have better outcomes even if you're providing the same evidence-based intervention. So the leadership, the management, and the staffing is really, really important. This is what standards look like. So they have a standard statement. They've got normally criteria that bring the statement down to a level where things are measurable, suggested scoring, and the evidence or verification that's required. And in the UNODC quality assurance mechanism, we've got variable sources for the QA process, documents, monitoring data, patient surveys, etc. And the consistency of the methodology is really important, as is patient feedback. All of this then results in, supposing you've been into a service, it's been assessed against the quality assurance standards, and you come out with this is a scorecard. So we then rate the different criteria, red, amber, and green. We've found this is culturally transferable, and then we ask services to improve those things that are red or safety critical. And then it's back to we trying to implement this quality assurance cycle. Okay, we successfully piloted this in Afghanistan. Again, please refer to the poster. I won't go into this in detail. I'd just like to name check and thank US State Department for the funding of this pilot, and also the Ministry of Public Health, who have taken this on board. Dr. Waffa was going to be here, but he couldn't get his visa in time, which was a real shame. But they took hold of this tool, they culturally adapted, they picked a subset of standards. We trained an assessor team. They went out into services in Afghanistan. We got around 16 out of 20, couldn't get to 4 because of the active conflict in the country. And the pilot was judged a success and then mainstreamed into their public health department. So it's a real success story. And the team had to work hard to overcome fear of scrutiny, resistance from some of the services, but the whole pilot also identified some system-level gaps around things like lack of clinical protocols, etc. And then so UNODC and other people have been then working to fill those gaps. So it was a very interesting pilot. We've then trained experts from 12 countries. These are the flags. All the countries that we work with are asked to look at and plan for how to implement the QA services, hence implementing ISTDUD. Okay, and an example of this is the Central Asia countries, so the STANs, are now looking at the standards and the toolkit, comparing that with their extensive existing quality assurance mechanisms, identifying the gaps, and then they're going to bring that and plan to implement in line with that. It's very, very interesting. International collaboration that we've been doing on the essential standards involves EMCDDA, COPOLAD, that my wonderful colleague Teresa will talk about, and UNODC. And there is a huge overlap between all of the work that we're trying to do. And duplicating doesn't make sense. So we've been trying to look to see whether or not we agree a group of essential standards to take those forward. And one of the things we'd like to say is that whenever we ask this exercise to be done, okay, in a country you're implementing quality assurance, please pick the standards that you think that you need to implement quality services. 85% of the standards that the countries pick are the same. It's really interesting, and it was the same when we did the exercise. I just want to flag to you the wonderful work we're doing in Nigeria. So our Nigerian colleagues are amazing. So they jumped off the block as soon as ISSUP was published in 2016 and produced a standards document on the back of it, this one, for their hospital services. Sadly, it wasn't implemented. It sat on a shelf. There was no mechanism to do so. But in 2018, we developed their clinical guidelines on the back of this document and in line with this document. We've then done essential standards pilot, and then we're dovetailing both of these initiatives in their next drug strategy, their annual plan. So there's a group of Nigerian experts. There's about 60 people involved in all of this, and they've been marvelous. Recently, we did a pilot of the QA process in Kano State, and I just wanted to flag this to you. So 15 services were assessed in June. I changed my presentation last night because I wanted to include this. And the results were the services were very variable. There were some really, really good services. But we went to Kano because we knew some services were very poor, very poor. And the poor, I've put some photos of what poor looks like in some of these countries, okay? So some of the services were really good, and let me stress that. And the experts in Nigeria will help capacity build the poor services to try and get them to the quality of the best services. But these photos illustrate some of the challenge that we have. So the next steps on this are targeted improvement, disseminating the guidelines, etc. So my conclusions are, people with substance use disorders are entitled to the same effective high-quality services as any other patient group. So it's our duty to do this, and we have this within our gift and within our remit. Quality assurance can really help implement international standards, but it's a step at a time. It's a small chunk of standards at a time. Try and do too much too soon, and it's not possible. Quality assurance can also ensure the benefits of training can be retained in the services, ensuring there's clinical supervision, service protocols, etc., to embed the interventions. So quality is everybody's responsibility. Thank you for the opportunity to speak, and it's a pleasure to be here. Thank you.
Thank you so much, Annette, for describing this important work on quality assurance, but also for your enthusiasm in doing that. And our next speaker has already been mentioned. So Teresa Salvador from COPOLAD, and I think you will explain in more detail what COPOLAD is. Teresa is a director of COPOLAD, and she's going to speak to us to the contribution of COPOLAD to promote evidence-based policy and programs in the field of drug demand reduction in the CELAC region. And also Teresa has close to or more than 30 years of experience in the field of substance use. She has been working in Spain, in the EU, with international organizations such as the World Health Organization and UNODC. And and we have especially recently been cooperating on this work of treatment quality. So thank you very much for being here, and the floor is yours, Teresa.
Thank you very much, Anja. You can hear me well? Okay. I like to move, that's why I asked for this. Well, thank you very much to ISSUP organizers, and thank you, Anja, for your introduction. It is really a pleasure to be here this morning with my dear colleagues that have been working in the same line that as we have been from COPOLAD. I will try to explain a little bit what COPOLAD is, because as Anja said, we focus on Latin America and Caribbean countries. It's COPOLAD. It's a European Union funded project that it's now in the second phase. It started in 2011. And we've been working almost for 9 years now, and we are in the last year of the second phase. Here you have the countries that are part of the consortium, and we have the real amazing cooperation with agencies and multilateral institutions, such the European Monitoring Center for Drug and Drug Abuse for Europe, CICAT HOAS in the region of the Americas, and PAHO also from America, and some non-governmental bi-regional networks. So this is something that explains why the name of a cooperation project, it's not really explaining what it is, because all the things we do, we are relying on all the partners that are included in the project. So it's not a cooperation. Usually cooperation projects are providing money and resources in particular countries to develop different things. Here we are learning from all the experiences gathered by all the institutions that I have mentioned before. And I feel very privileged to have been able to be in this project since the end of 2010, because we think that this project came in the right moment. For more than 4 decades, the drug demand reduction field in the world, not just in Europe or in the Americas, I think all over the world, we were starting to work in a period which could be defined as the period of magical thinking. And the main trait of this period was to respond to a social alarm, towards a newly emerging problem. Also, it had a lot of ideological bias. It was based on voluntary interventions, most of them isolated and based on goodwill of the promoters. They intended to save the world with no resources. They had poor or no planning at all. They lack of evaluation, and anything was considered to be okay as long as something was done. Okay, fortunately, in these 4 decades, which is a quite short period in human development, we have progressed a little bit, okay? We have now an increasing institutional experiences from the agencies responsible for drug demand reduction policies. We have research findings that are quite important. Even if we don't know all the answers about what works or what doesn't work, we had a lot more information than 4 decades ago. We have the resolutions of UNGAS, which also my colleagues were referring to earlier, and we have the development objectives 2030. So now we are progressing towards needs assessment, attention to evidence, public policy, evidence-based intervention models. We are considering cost effectiveness, as also my colleagues mentioned it. We are defining strategies, national strategies, and national plans to implement those strategies. We talk about the need of planning and evaluation, and we know that good intentions might do more harm than good. In Spanish, we have a saying that says that the hell is full of good intentions. Okay? El infierno está lleno de buenas intenciones. So now we know that, and I feel very privileged because COPOLAD started just at the right time, and just to try to sum up forces with other developments that were already in place in the Americas. So from the very beginning, we had very clear that we were going to support processes that were already going on in the Americas. We were foreigners, and we had little resources, so we couldn't make miracles, but we wanted to support what was already in place in the Americas. And also we had as the background framework, as the model framework, the European Drug Strategy 2013-2020, the Hemispheric Drug Strategy, which was compiled by CICAT-OAS, also WINGAS, and the Sustainable Development Goals. So our main objective was to attain a significant number of countries adopting key processes and tools to enhance planning, quality assurance, and evaluation. That is easy to say, but not easy to implement, but that was the main aim of the project at the beginning. And our main lines of action was quality assurance, capacity building in the sector in Latin America and the Caribbean, development of planning and evaluation support tools, and reinforce and enhance the role of national observatories and the national agencies on drugs as the institution responsible for those. We decided that taking into account a needs assessment, listen to the country needs, making also attention to several evaluations we did at the beginning, at the middle, and at the end of the first phase. Also looking at the information that the MEM from CICAT-OAS is providing. So with this needs assessment initially, we started COPOLAD 1 in 2011 with those aims I set. In COPOLAD 2, which we started in 2016, what we tried was to follow those lines of actions, but very oriented towards changes or towards helping countries to make changes in practical terms in the ground side. So all the things we've been doing since 2016, it's been action-oriented to support countries to make progresses, okay? And in the line specifically of quality assurance, that it can be summarized as a process of consensus that we started. I am going to go quick because I know it's time consuming this, but we started a process of consensus based on all the progress that were made, especially by United Nations and WHO at that time, and 2011 when we started. And those were the main documents, and also a literature review that we did before making a proposal to a very broad audience, which were experts and drug agencies responsible for drugs policy in the Americas. Okay, after this Delphi process that was based on the evidence review, earlier evidence review, then we did some focal groups. This involved more than 120 experts from all over the region. And I want to stress that because, as also my colleagues have mentioned, the guidelines published for many years are sometimes difficult to follow in practical terms because nobody has time or has the effort to do that. So we wanted to involve the people that were working on the field for many years and facing the difficulties and facing the reality. And that's what we followed this Delphi process and the focal groups afterwards. And finally, an advisory body that was composed by the national agencies, CICAT-OAS, PAHO, and the MCDDA, were finally identifying 174 quality standards. I'm not going into the detail, but I wish to point out that our classification, I don't know how this can be pointed. No? Yeah. Oops. Our classification, it's organized on common drug demand reduction standards, prevention standards, risk reduction, treatment, harm reduction, and social inclusion. And each area has different categories: structural standards, functional or process standards, and evaluation standards. Okay, those are the standards that were finally, after this process of consensus, we came out at the end of 2014, and that is reflected in a publication. But apart from that, what we got also was the commitment of national agencies and multilateral agencies to support further this process in order to help countries to implement quality assurance. In the second phase of COPOLAD, starting 2016, the Caribbean countries went into the project, and also we were sharing with them what we had produced along with the Latin American countries. They had already some common standards on treatment developed in the Caribbean. They thought that it would be good for them to join our process, so they were joining our process at the beginning of 2016, and they did the translation, language validation, and also indicators and verified consensus, and the piloting. Okay, where are we now? Well, we have since 2016, we started this piloting and validation of those standards in 22 CELAC countries, including Latin America and Caribbean, and we had 3 national agencies from the region leading the different processes. SENDA Chile, the agency responsible for drug policy in Chile, was leading the treatment validation standards. Costa Rica, the ICD agency, was leading the validation of the prevention standards, and the National Drug Council on Trinidad and Tobago was leading all the process in the Caribbean countries. Okay, to start all the validation, which is very much the same as Annette has described for your standards. We did some training of the different groups in Santiago de Chile, in San Jose, Costa Rica, in Jamaica. All that was between 2017 and 2018. The training was on a common methodology to make sure that they were using, they were doing a language verification. Even with the Spanish, we had done a language verification because it's not the same as Spanish we talk in Argentina that in Chile or in Costa Rica or in Mexico. We had also a clear definition of what the indicator, a verifier, and threshold compliance, and we had the piloting. In each of those initiatives, we had an expert group coordinating the whole process, and also at national level, we had a national multi-sectoral panel that was composed by the Drug Commission, the Ministry of Health, the Ministry of Education, universities, civil society, drug observatories, and experts individually to follow all the process of verification and validation. And we had, after the implementation of the piloting and validation, 2 meetings to summarize the results in each area. For the Latin American countries, we had this meeting in November in Santiago de Chile, and for the Caribbean countries, just now, 2 weeks ago, in Paramaribo in Suriname. Okay, and now the good news. I think that I just want to leave you with good news. Okay, from the 23 countries participating in the process, 22 have finished the validation, the verification and validation process. Okay, they have successfully finished, and we have only 1 country, which is Paraguay, that was intending to start the validation of the treatment basic standards that couldn't make it, and it's at the moment having no results because they couldn't follow the process. I have to say that I really appreciate the work of all the countries participating because it was a hard job. And we didn't have much resources to do it, and they were doing a big effort to perform this validation. And I want to thank the leading agencies, but also the particular countries, each one of them making this amazing job, okay? And here there are some other good news. I think that Annette said there are services or countries that are meeting some standards already and some other standards are not meeting it. Okay, this is the same we are finding at the preliminary results. When we look at standards applicable in all the countries participating, 98% it's applicable what we are proposing. But then the picture is different when we look at what it is really going on. So, but this is a good news because it means that there is a lot already advanced, and I think that we can we can follow the support from here because this is very promising, okay? The same for, okay. Now, I want to also emphasize that another good news in this process is that, as Annette has already mentioned, we are following an harmonization work. She called it overlapping things between both projects. I like to call it meeting synergies because really, actually, we are coming from the same roots, and what we have seen is that we are really working towards the same objective. So I'm very happy, and this, I think it's a very good news. We had 2 meetings in Washington, one at WHO, and the last one where this basic common standard was agreed. It was at CELAC was in February recently. So what I want to stress is, at least for what we are trying to do in COPOLAD in Latin America and the Caribbean countries, the prospects are very, very interesting. And the only thing I want to say is that all this, it's just trying to add some operational support on settings and standards needed and the tools that have been using to really increase the quality of the interventions in drug demand reduction. And finally, and I finalize with this, in COPOLAD we have 4 online courses that have regional and national editions, which are trying also to sum up on those lines for policymakers. And we are developing some support tools. One of it is One Step at a Time, which is an interactive planning and evaluation system, which we are starting to use through some workshops, regional workshops. And the first one will be in Buenos Aires in 3 weeks' time, and we'll have another for Central America and another for the Caribbean countries. We have also an instruments bank, and I don't want to use more time. Thank you very much for your attention. I hope that with my bad English, I've been able to explain what we do. Okay, thank you.
Teresa, thank you so much highlighting all this work done between the CELAC countries and the EU. I think that's really fascinating, and also highlighting the complementarity between the approaches described before and all the work you're doing for so many years now already, kind of with the Latin American countries. Now we would like to move to the last speaker for this session. After that, there will be a time for a question and answers. And it's our pleasure to give the floor to Dr. Randy Koch, who's an associate professor in the Department of Psychology at Virginia Commonwealth University in the United States. He also has been working more or less in the same time frame like the others on issues around substance use and research, and had a particular interest also in quality assurance protocols for drug treatment, and as Annette has mentioned, has also been part of the early group kind of working on the UNODC quality assurance documents. So Randy, the floor is yours.
Okay, thank you, Anja, and good morning, everybody. So a few months ago, I attended a workshop on public speaking. Okay, good morning. So a few months ago, I attended a workshop on public speaking, and I suspect after you listen to me a while, you'll understand why I did this. But the workshop leader said something that I thought was really interesting, and he said he advised us to follow the recommendations of Aristotle, who said that if you want your audience to remember the key points of your presentation, you need to tell them what you're going to tell them, and then tell them what you told them. So I thought this was really interesting, although first I was kind of suspicious, so I actually Googled it, and in fact, Aristotle did say this. So I went home and I told my wife about it. I said, you know, this is how you need to make sure that people really understand what you're trying to say and remember the major points. And she paused for a second, kind of looked at me, and she said, do you think it works with husbands? So I don't know if it works with husbands or not, but I'm going to try it today, and we'll see how it goes. Okay, so this is what I'm going to tell you. Patient surveys can be a useful tool to help assure the quality of addiction treatment services, but they do have distinct strengths and weaknesses that you need to consider. Conducting patient surveys requires attention to several methodological issues in order to maximize their effectiveness. I'm going to talk about some of what those methodological issues are and recommend some what I'm going to call best practices. And then finally, there are existing patient surveys that can be adopted or adapted for use in your programs. And I'm going to mention a few of those and then go into a little bit more detail about one that I think is particularly relevant to low and middle income countries. Okay, so this is a rather dense slide, so I'm not going to go through it in detail. But the main point here is that there's lots of different sources of information to look at treatment quality. And I've divided them into kind of three major categories. So they include kind of existing data that comes from administrative data and program documents, so things like admission and discharge forms, program procedures and policy manuals, things like that. These tend to be kind of low cost because it is existing data. The value can vary between low and high depending on the quality of that information and what you're trying to measure. Then, of course, there's standardized instruments, things like the Addiction Severity Index. The cost is quite high because it requires a lot of training, a lot of time to administer, but the value is also very high. And then kind of in the middle, I think, are surveys, including patient surveys. So I think they have kind of a medium cost relative to the other types of sources. And their value can range from medium to high depending on a variety of issues. Okay, so what is a patient survey? And this may seem obvious, but the reason why I included this slide is that so often when I mention patient surveys, people assume, oh, patient satisfaction. And yes, that is one reason to conduct a patient survey. And this dates back to probably the late 1970s, early 1980s, with the work of Clifford Atkinson and his colleagues who developed the CSQ-18 and later the CSQ-8. But it really can be much more than that. Patient surveys can be used, for example, to measure outcomes. So there's a growing area of patient-reported outcome measures, or PROMs. They can also be used to measure treatment process, so what happens in treatment, and quality. We could talk a little bit more about this issue if we had time, but I think that the addiction field really lags behind other areas of healthcare in using patient surveys, including the mental health field. And I think there's a variety of reasons for that. A lot of it has to do with our perceptions of clients in treatment. And again, we can talk about that later if there's time. Okay, so why use patient surveys? So one is they're very flexible. So you can write survey items to address just about anything you want to measure, and you can also modify those surveys over time as new issues arise, new areas of quality that you want to explore. I think the patient perspective is absolutely critical, and I think we don't often get that. And yes, objective data is important, but let me give you an example of why it might be important to get the patient perspective. And this comes from a true example. So in one of the surveys we were doing, one of the kind of quality studies we were doing. We measured the amount of time from the time the patient requested service until the time the patient actually had a first meeting with the clinician. And it was something like 5 or 6 days. I don't remember the exact number. But then we also, and that seemed pretty good to us, right? I mean, that's pretty fast. So then we asked the patients about how accessible the services were, and were they satisfied of how quickly they got services. And lo and behold, we found out that they weren't that happy with that. So their perception was that they needed services even more quickly. You know, they want services on demand. They want to walk into a clinic and get services that day because that's the day that they're ready to receive. Okay, also it demonstrates respect for patients. It's really, these tools are less burdensome on clinicians because they're relatively easy to administer. They don't require a lot of training. They also don't require a lot of technology. Technology can help. It's great if you can automate your survey and manage the data electronically, but you don't have to. You can go back to adding things up by hand if you want and reporting it. And then finally, there's good measures in the public domain, meaning that they're free to use. Okay, Annette mentioned already that patient surveys are included as one source of data within the quality assurance tool. I think there's around 15 different criteria that mention patient surveys as a method for assessing compliance with the criteria. These are just a few examples. I'm not going to go through those in the interest of time, but it's really kind of a broad range of quality standards that can be looked at through a patient survey. Okay, there are a number of methodological issues that I think have to be addressed in using a patient survey and also particularly in developing a new patient survey. And I think the take-home message from this slide is that this is not an easy thing to do. This is not something that somebody goes into their office for an afternoon and writes out a survey. It just doesn't work. The quality of data you get back from that sort of effort is not going to be worth the paper that it's written on. Okay. So one methodological issue is something called demand characteristics. So this is something that comes from a lot of other areas of research, but basically, you know, the person completing the survey is trying to figure out, well, what is it that they're looking for? And too often, what the patient thinks the clinician or the program is looking for is positive feedback, you know. And so oftentimes, if you're not careful in developing your survey and in how you administer it, you're going to get a lot of just positive responses that don't really reflect what the patient thinks about the services. But there's lots of ways of addressing this in terms of the instructions you use, how the survey is administered, who administers it, and so forth. A somewhat related methodological issue is patients' fear of losing services. This particularly occurs in areas that are under-resourced and where patients may think that, well, the services aren't really that good, but they're better than nothing. And so if we don't give positive feedback, there's a potential that the program will not be funded. So we're going to say positive things. Again, I think this can be addressed in how you administer the survey and so forth, but it's something you need to be aware about. Confidentiality is a huge issue. Obviously, if patients think that their responses are not confidential, that's going to affect the validity of their responses. Selection bias, another huge issue that's really difficult to address with patient surveys. One of the biggest problems is that you miss people who've dropped out of services, really kind of no matter at what point you administer the survey, because a lot of patients drop out very early. You're going to miss some patients, and you need to be aware of that. And they're likely to be the patients, obviously, who are most dissatisfied with the services, most critical of the quality. Language is another reason that creates selection bias. So oftentimes, there may be multiple official or common languages in a country. So that if you only use one or two, you're going to miss people. Oftentimes, the people you miss because of the languages you choose are the people who are most disadvantaged and have the most difficulty engaging in treatment. Literacy level is another challenge, so you really need to be attuned to kind of the reading level of your population. And of course, all of the above affect the reliability and validity of your measure, which means that you really need to go through a careful process of development, including cognitive testing and psychometric testing. Okay, so this lists several examples of patient surveys that I've been involved in at some level. They're all kind of public domain, so they're free to use. I'm going to talk a little bit more about the last instrument, the South African Addiction Treatment Services Assessment, or SATSA, again, because I think it's probably one that might be most relevant to you from, who are from low and middle income countries. So normally at this point, I would go into some detail about how we actually developed that instrument, but there's just not time to do that. So let me just kind of give a big picture about what we did. So first of all, we involved a very broad group of stakeholders. We thought that it was really important that we got input from clinicians, policymakers, patients, et cetera, to identify what are the critical issues related to treatment quality that we need to address. Second, we wrote, rewrote, and rewrote again the survey items. I can't tell you that how important this is, how much time you need to devote to this. Writing good survey items is difficult. And you need somebody who has some experience in doing this, and you need a team to kind of do this and kind of review and rewrite. We then went through a step of cognitive testing, a step that's too often neglected in survey development. And then finally, 2 rounds of pilot testing, pilot test and psychometric analysis. And we use both classical test theory and item response theory to look at the psychometric qualities of the instrument. So that's in a nutshell what we did. And here's the result. So this is the SATSA, and on the left-hand side is kind of a picture of the first page. It's a 26-item survey. It takes about 10 minutes for patients to complete. And in South Africa, what we've been doing, although there's multiple options for this, is we've been giving it to patients in outpatient services between 3 and 4 weeks after admission, and for those in inpatient services, and we tested it in both populations, we give it to people at discharge. So the instrument has 2 dimensions, effectiveness and quality. Within the effectiveness dimension, we assess substance use, social connectedness, quality of life, and sexual risk behavior. And then in the quality area, we assess access to services. And then we have kind of a general quality scale that has things like staff treatment with respect, for example. Okay, so just one slide of psychometrics. So these are the internal consistency coefficients, Cronbach's alpha, for each of the 6 scales. And you can see, if you are familiar with looking at Cronbach's alpha, that they range from acceptable to very good. So 0.72 at the low end to 0.89 at the high end. And if you want more detail on the psychometrics, I'm happy to provide that. We also asked providers what they thought about the SATSA. And I'm not going to go through this in detail, but their response was very positive. They thought it was easy to use and that it was helpful. And in particular, and most important to us, that it provided information that helped them improve the quality of services. Okay, so what have we learned from this experience in South Africa, as well as just kind of normally what we know from the science of survey development and administration? So first, always involve key stakeholders. I mentioned this earlier. You really need that involvement to develop a good instrument, but also for political support to hopefully get people, programs to use the instrument. Again, write and rewrite survey items and or borrow good items from existing instruments. Conduct a Lexile analysis to ensure appropriate reading level. This is actually really easy to do. MS Word actually has a function on it that gives you the reading level. But you need to know the reading kind of your population. So when I've done this in the United States, we've used a reading level of grade 8. In South Africa, we used a reading level of grade 6. It's just a different population. Need to make it available in all major languages so to reduce that selection bias. You need to conduct cognitive testing with a similar population. You need to do pilot testing for both the psychometrics, but also for the survey procedures to make sure that you can administer the survey efficiently without too much burden on staff. And you need to revise and pilot again. And maybe again, if the psychometrics don't work out. Okay, so best practice in terms of survey procedures. Determine the best person to administer the survey. You can choose from clinicians, administrative staff, volunteers. There's not necessarily one right person to administer a survey, but you do need to be attuned to the issue of demand characteristics. You need to select the right time to administer the survey. You have lots of choices. In outpatient services, I think there's two good choices. One is to pick a standard treatment interval. As I mentioned in South Africa, we picked 3 to 4 weeks after admission. We thought that that would give people some time to, some experience in treatment, so they might have some good impressions about quality, but also not so long that we've lost a lot of patients. Another approach that I actually really like, and we've been using in the United States and my home state, is we do it in a cross-sectional fashion. So programs once 1 week during the year, or sometimes 1 week twice a year, administer the survey to everyone who comes through the door that week. So it's really easy. It's like, you set aside the time that 1 week, you do it, you get it over with, you get your results back, you interpret it, you figure out what they mean. That seems to be a very easy, efficient way to do it. If you're in an inpatient facility, what we found works best is to actually administer it at discharge. So it just becomes part of the discharge paperwork. So I'm running out of time, so I will try to speed up. Importantly, you need to use survey procedures that kind of fit the organizational structure and their process, and you need to provide extensive training to program staff and ongoing support. Okay, well, this slide didn't work out so well. So need to ensure patient confidentiality. Again, this is really important to prevent to make sure you have valid responses. It's best just to make sure you don't lose data, to assign responsibility to one person for managing completed surveys. And remember that some patients are not going to be able to read the survey. They're going to need some help. So have somebody available to actually read the survey to them. Best practices in terms of reporting and using results. Reports need to be easy to read and understand by key stakeholders. This means everybody from managers, funders, clinicians, and also patients and family members. You need a formal process to interpret and develop a QI plan in response to the results. And I think if you don't have a formal process, too often the survey results just sit on somebody's desk. And I recommend, again, that you involve all key stakeholders. We've done focus groups of patients and clinicians to understand what they think the results mean and develop strategies to address any kind of deficiencies that are identified. Okay, so to conclude, here's what I told you. Patient surveys can be a useful tool to develop and assure the quality of SUD treatment services. They do have distinct strengths and weaknesses. The strengths include things like they're flexible, they're easy to use, they're kind of low cost. Weaknesses are some of the methodological concerns that I'll mention in a second. So conducting patient surveys require attention to several methodological issues in order to maximize their effectiveness. So I mentioned things like attention to demand characteristics, confidentiality, selection bias, and I mentioned some ways to try to address those. And then finally, there are existing surveys that can be adopted or adapted for use in your programs, and one that I'm kind of invested in at this point is the SATSA, and I'm glad to talk to any of you about how to use that if you're interested. This is a list of publications based on the SATSA and our work in South Africa. If anybody wants to go into greater detail on this and see the psychometric testing that we did. This is our project team in South Africa, and I definitely need to mention Bronwyn Myers, who is the PI on this project. And a thank you to the funders of this work, who were the Centers for Disease Control and Prevention in the United States through their PEPFARS program, and the province of the Western Cape of South Africa, in particular their Department of Social Development. So thank you very much.
Thank you very much also for walking us through really the scientific, but also the very practical elements of patient surveys and their role in quality assurance. And I think we all can agree that you did as you learned in your public speaking course, so also that well done. So we have let's say 5 to 6 minutes still for any comments or questions from the floor, and I would say maybe we take maybe 3 or 4, and then we give a chance to respond, and then we take another round. So I take one on this side, one on that side, but I've seen you, but okay, so I have Dimitri, then maybe you start, and then we continue there. Yeah, there are many on this side.
Good morning. I just can't resist about sharing with you a story. So we did a survey in 11 countries on patient satisfaction with inpatient treatment of severe mental illnesses. And it had two components, quantitative and qualitative. And so just a case story of patient who rated the satisfaction to 10 out of 10. And then there was a comment saying that, well, everything was very nicely, but maybe it would be slightly better if I'm not tied to bed every day. And the conclusion from this example and from the study overall is that satisfaction depends a lot on expectations. So if patients expect that the coercion is part of treatment, they will just consider it as appropriate and they would be satisfied with treatment. And I think here we have a problem that we need to educate probably patients about what is the good service before measuring their satisfaction.
Thank you. Maybe we'll take a few more from this side. Andre?
Alexander Kancho from Sofia, Bulgaria. To Ms. Annette Pereira, first of all, I would like to express my admirations for your excellent work. And if you allow me, I have two questions related to quality assurance implementation at national level and the problems that may arise. First, both treatment systems and health administrative systems are well known that they do not like to be told what to do. And they don't like to be told that they are not doing well. So they have a tendency to resist any change and maintain the status quo. How do you deal with this? And the other question is, of course, there is a risk that health institutions at governmental and ministry level may use the quality assurance as a means to control, provide pressure on the treatment providers. What is your recommendation, how to prevent that? Thank you.
Maybe a third one, and then we leave. Maybe one of you in the back there.
Hi, I'm Ian Tully from Hamad Medical Corporation in the Ministry of Public Health in the state of Qatar. I really wanted my question towards Colette. She talked about the difficulty in the implementation of some of this stuff. She talked a lot about the what standards, but the challenges of how those standards are implemented. And she made mention to the fact that she went back to the front line after 15 years to see what difference had been made. So my question is, what difference has it made?
Yes, and maybe a last one here, and then we close for.
I like to have the panel talk about the importance of participatory processes, because one of the things I heard in every one of your presentation is that getting your task done require creating the participation of all the important stakeholders.
Excellent comments and questions. Maybe we start, I don't know, Randy, do you want to comment on Dimitri's comment? Or?
Yeah, just a quick comment. So when I first started working on patient surveys back in the 1990s, I was told that it was going to be a waste of time because all the patients would just say the most positive things. But I think that, well, it turned out that that was not true, and I think it had a lot to do with the process we used for developing the patient surveys and the instruction we gave. And actually what we found was a lot of variability, not only within programs, but also across programs. So if you plotted the scores, you'd just see these, kind of short, it's like a lot of variability. It's also because we didn't just ask a simple question of, were you satisfied with services? That's an important question, but we dug so much deeper into kind of their perceptions about different aspects of treatment. And I think so that's really what you need to do.
Thank you. Ellie, I think the second question was to you. It was around if treatment systems do not like to be told and they might be resistant kind of to the results of quality assurance processes.
Thank you, Anja. I thought that the question was more for Annette, but I'm happy also to respond. And Annette, you feel free to jump in. Well, definitely, and I think that when we did the pilot in Afghanistan, we saw that happen immediately. There was a response from the providers, many of them non-governmental organizations, that feared that this process may point out at things that were not being done properly, in their opinion, and therefore stop the funding from the government, etc. And another factor was precisely what you mentioned, the possibility of the QA process being used as a mechanism of control. So I think that in the process of implementation and all this consultation, cultural adaptation, etc., has to serve the purpose of also building up that confidence that the main goal is to improve services. The main aim of all these processes is that our patients receive the care that they deserve, because it's a health disorder, and it should be treated like any other chronic disorder. I don't know if you would like to add something to that, but I find this as...
Maybe Annette, if you could then also a little bit respond to the second.
Thank you for your question. It's difficult, I think. Quality assurance necessarily involves working with resistance. And I think for me there's something about if we just put out quality standards and guidelines, it's not enough. There needs to be some kind of levers over the provider or the funders in order to get that implementation. There is something also in, if we're using public funds, there's something about public accountability for money. If this is state funded, or if there's any kind of a public accountability, I think that there's a duty on all of the providers to be accountable for that money and to demonstrate their effectiveness. But I don't think it's easy by any stretch of the imagination. And I think different countries will have different levers to pull and push. So sometimes that might be linked to the funding of the treatment services. Sometimes that's linked to legislation. Sometimes it's linked to kind of goodwill. I always would recommend that there is a bit of push and a bit of pull. So a bit of the nice, fluffy, we're doing this for the benefit of the patients, but also some teeth in there. Ian Tully, hi. 15 years going back into the field after having written lots of national guidelines. Well, you know, you learn from your mistakes in this business. In my country, I mean, the British are professional bean counters. We tend to set up systems that are publicly accountable. So not only do we put in quality standards and we inspect everything, but we put the results on the web for everybody to see. So everybody knows kind of your kind of quality. I think my key learning going back was that I reckon for all of the guidance we put out, maybe 30% of it had been implemented. I thought that was good going. We'd had some unintended consequences because we'd linked some of the guidance to key performance indicators as a way of having levers over the system. So we'd linked it to performance monitoring, and we'd linked that to money, and we'd linked that to the way that things get funded. And whilst that helped embed things, it also had some negative consequences in terms of the shape and direction of the system. In terms of the services on the ground and the staff, they could never do more than change 3 things at any one go, basically. So it had to be small steps.
So, sorry to follow up, if that's okay. So as a country that's trying to develop its substance use services, and a country that's very interested in the outcome for those patients that will be served, what's your advice? How do we leapfrog the mistakes that have been made, not that you've made, but that have been made elsewhere?
Can we just have a very quick answer?
Let's talk in the coffee break. Yeah. It's complicated.
And then there was also a question to all the panel, but maybe we'll give to Teresa first on the importance of participation in these quality assurance processes.
I think the importance of participation of all stakeholders also answers the question of the difficulties or fears from public administrations or services to be evaluated. Because first of all, we have to understand that quality assurance is a process that cannot be implemented from today and tomorrow, and that's finished. In Latin America, for instance, the country that has been able to implement a quality assurance system on treatment services, which is Chile, they have been working on it for 12 years. So until they had implemented in a regular framework, legislative framework. What does it mean that? It means that if you you start involving all the stakeholders in a consensus process, also along this process, you are first of all, ensuring them that it's nothing against them, as Elizabeth was pointing out. It's a process that you are developing with them in order to get them more satisfied about what they are getting from their work, and they appreciate that. And we've been able to validate this in all the process of Latin America and Caribbean countries participating. It was a difficult exercise, but they all were overcoming fears and saying that afterwards, after the piloting, they are satisfied. Of course, this is only the first step, but if you involve a multi-sectoral national group of stakeholders, you can face those fears, you can work with them to train people in the sector in order to see the advantages of quality insurance in the system, and you can also be able to see the good results that those progresses are giving to the professionals themselves. So I think that's the way that this can be faced, but it's not something that can be solved in one day, in 1 month, in 1 year. It takes time and is a process.
I think for the sake of time, we will be closing the panel, but before we do that, we have an announcement. So the organizers of the conference, ISSUP, ask us to inform you that there are still vacancies in different trainings that are going on in parallel to plenary. And if you're interested in participating in one of those, and maybe you haven't signed up before, you can actually still go there and sign up on the spot. On page 33 of your brochure, this one, right? You find the information on the trainings. So just to say that this might be an opportunity still, unless the particular training might be one of those that's already very overcrowded, of course. And Elizabeth also just reminded me in terms of the quality assurance work that UNODC has done. We have printed posters with kind of key messages in different languages, and they're available just outside to the right. There is a stand kind of from UNODC, and you can just go and pick them up. And they are also available on the website, by the way, but downloading is a little bit heavy. So with these announcements made, I would like to close the panel. Thank all panelists, thank all of you. And I think if you still have questions to the panelists, they will still be around at least today, but also for the rest of the week, I think most of them. So thank you very much.